So thank you for asking me to come and share some thoughts on safe supply. Next slide. I have no relationship with the pharmaceutical industry. I am going to be getting a small honorarium from the government of Alberta to sit on one of their committees, and no perceived conflicts of interest. Next slide. For this session, I'd like to be able to place the current crisis in context, to list some pros and cons of safe supply, and to identify other evidence-based options to address the opioid epidemic. Next slide. Substance use represents the top preventable cause of death worldwide, according to the World Health Organization. Next slide. It's not just an opiate crisis. In Canada, alcohol is the #1 cause of hospitalization, with more admissions than opiates, stimulants, and cannabis combined. And even hospital admission rates for cannabis are similar to opiate-related causes, but we're not hearing about any of this in the media compared to the opiate crisis. So really, we have an addiction crisis in Canada. Next slide. Some of the previous speakers that you heard today went into detail around the opiate crisis, so I won't go in great detail on this slide, but just to understand there is a significant role of big pharma that created this, including lobbying, paying for textbooks, promoting pain as the 5th vital sign, and incentivizing physicians to prescribe opioids. They also recruited patient advocates to be the face of pain, and did not bring forward the people who are becoming addicted or having trouble with their medication. Palliative care docs and anesthesiologists opened chronic pain management centers using medications typically confined for hospital use, and other doctors followed suit. So doctors played a role in one of the waves of the crisis, and with no upper limits to prescribing, guided by the patient's pain experience and sympathy of the doctor for the patient. And we now know that 75 to 80% of injection heroin users started with the prescription opioids, to which they got tolerant. Opioids not only relieve pain, but cause pain, which I do research in that area. And opiate withdrawal pain particularly is a driver of reinitiation. And again, we can talk more about that in the question period if you like. Then the tainted blood supply with contamination of all sorts of things you can see listed on the slide. Next slide. Just to understand that all of the things you see listed on the screen can affect someone's addiction liability or that risk to a population, but the key thing that cannot be done without is exposure. So if you don't have exposure, you don't have a substance use disorder. And by reduction of exposure or elimination of exposure is one way to intervene. So we have not talked at all about primary and secondary prevention, which is part of what's important. Next slide. When the COVID-19 pandemic hit, there was a need to self-isolate and quarantine, and an increase in contamination of the drug supply as just supply chains got cut off and rising deaths. The BC CDC and the BC CSU created new guidance on prescribing pharmaceuticals, opioids, stimulants, and benzodiazepines that were outside of evidence-based treatment. So these were not medications that had been studied or that usually were provided for opiate agonist therapy, OAT. This was to take home unsupervised that people could use orally, but many people were snorting and injecting. The term pandemic prescribing, also known as risk mitigation, also known as pharmaceutical alternatives, also known as safe supply. These are all euphemistic names, but I will use the term safe supply in this talk because that is what the committee is choosing. This is a form of medicalization versus decriminalization and legalization, which again, we can talk about in the question period. Next slide. So the hope for outcomes, again, there's no published data, but the hope for outcomes when this was rolled out in British Columbia is that it may be desired by a certain segment of the drug using population. It may reduce stigma to those. It may be more convenient than if they had to go in and get something supervised. It may help if someone had to quarantine. The hope is that it would mitigate overdose and that it might be less expensive than having someone have to witness in a supervised setting an injectable medication, which is inexpensive to have all the setup and the nursing staff, and that it may link users with care providers and encourage treatment. That is the hope. Next slide. There was a presentation last week by a colleague I respect, Dr. Paxton Bach from the BCCSU. It is not my data. I'm not going to present it in detail. This is my understanding of what they said from that hour-and-a-half presentation. Just some of the key features, that there's been 6,500 people who have received these medications. There's no intervention on this scale that would be rolled out without prior evidence that could be peer reviewed. So it's quite marked. And certainly no evidence was presented that it decreased overdose risks. It was anecdotal information around acknowledgement of diversion and around some patients wanting to unlink from physicians and nurses and healthcare providers altogether to get this information. There was some anecdotal evidence that people could self-isolate a bit better, and that some people did report some increased use, but many reported that they continued to use illicit substances. Next slide. The concerns I have over this is that on a population level, this is an experiment with no published data, the consequences of which may take years to see. Just like with prescribing opioids for pain, it took years to see all the impact. The potential benefits may be confounded. For example, in the data, they showed that about 83% of people of the 6,500 were either on an opiate agonist treatment, methadone, Suboxone, injectable, hydromorphone, or slow release oral morphine. They were already on that when they went and accessed the safe supply, or within a week of accessing safe supply, they got this. So it was mainly being given out by addiction doctors when people were already in, or as a way to help hook them into care. So when you look at potential benefits that may be rolled out by this research, it may be confounded because the benefit that they're seeing may actually be from the opiate agonist therapy itself and not as much from the safe supply. So this needs to be teased out. Some harms may not be captured right away, like infections from injecting, tablet formations that are meant to be taken orally, youth who may uptake and diverted supply, diversion, which includes increased availability, decreased cost of pharmaceuticals on a street level, which can drive up use and addiction in the long run. If we think of China and the opium that was pushed into the country, and Ohio and the OxyContin, as well as spread across Canada and the US. So these are the effect on society. Increased wealth and power of drug dealers purchasing low-cost diverted medications and selling them elsewhere. So one of my colleagues at Vancouver General Hospital told me a number of months ago that there was one of the well-known drug dealers from the downtown east side was in for a medical condition, and she sat down on the edge of his bed and asked him how he was doing financially, and he said it was the best thing that had ever happened to him. He made $1 million this year from buying up safe supply off the street from people who had it dispensed to them, and he sold it across Canada and to the United States for making a huge profit, because the street price of these drugs, as Dr. Matthews had mentioned, has tumbled down to just 3 or 4 pills for $1 instead of $8 to $10 a tablet. And so you can sell it elsewhere for an enormous profit. The other issue of coercion of vulnerable individuals being asked to sell their supply in order to have dealers make supply. Next slide, please. So some of my other concerns is that even the term safe supply can give this false impression that they're safe to use and inject, which may encourage needle use and youth to increase use. And people can still overdose on medical grade opioids. We have years of experience with pharmaceuticals. If diverted, an opiate naive person, someone who had not been using, can still overdose, but they thought it was safe because it was a medicine. Also, some sell their safe supply to buy fentanyl. There are people seeking fentanyl, as we know, and they can still overdose because of the fentanyl. And all stimulant trials have failed. So giving safe supply in the terms of fentanyl does not seem wise. You could give an opiate blocker instead to prevent contamination of overdose due to opioids if someone took a stimulant, but no one's talking in such terms. Next slide. Other concerns, it may pull people from stable treatment. We'll need to see. We need studies that look at this. It may delay treatment readiness if it's done outside of a treatment context, just handed out in a public health forum instead of by addiction doctors who are using it just as an engagement tool. It may palliate a treatable disorder, and this is one of my big worries, that just like with cancer treatment, if we did not offer all the evidence-based treatments and pull people into care and instead just gave them opioids and palliated their disease, there would be an uproar. So we have to make sure we don't do that with this particular condition. There will be people who decline treatment, just like with cancer. There are people who want homeopathic remedies instead of taking surgery, radiation, and chemotherapy, and that is their right, but that is not where we put public healthcare dollar. Special groups, youth, older adults, pregnant women, we're not sure how it affects them, and there has been no exit strategy articulated. Once you're on, what's the indication to get off? They were presenting the other day that even people who have negative urine drug screens for the medicine that they're prescribed are still given more of it. So what's the exit strategy? Next slide. There are evidence-based options, and I'm sure your committee will go through these: primary and secondary prevention, medication-assisted therapies like buprenorphine, methadone, slow-release oral morphine, and something we don't have in Canada but is available in the US and Europe is extended-release injectable naltrexone. It's like naloxone, only it lasts a month. You can inject it, and it's on board for a month. You can ask me in the question period about that substance if you like, but we don't even have it available in Canada, though I worked with some people to bring it in on special authority, but no one paid for it. Any government paid for it. And it now, the latest study out on this shows that it's even better than buprenorphine in terms of sobriety rate, 70% at 1 year and craving rate 1 out of 10. So behavioral treatments abound, and I've listed them there. Next slide. So to save lives, we need to fund primary and secondary prevention, offer treatment to all those who are wanting it, make treatment accessible and affordable, bring extended release injectable naltrexone to Canada, which is good, especially for people who have safety sensitive work because it's an opiate blocker, so people are sober when they go back to work, cover new formulations of buprenorphine, supervised consumption sites and injection sites need to be embedded in care if they are used, expanding naltrexone, prioritizing pregnant women, youth, and helping employers get workers back into treatment and back to work. And if you are going to decriminalize, do it in the Portuguese model: house, treat, medical care, etc.
Excellent, thank you, Doctor. I'm pretty sure the first question from the member was to ask you to just work through the last couple slides that you have there. I heard that question, so feel free to take a couple more minutes to finish your presentation.
Great, thank you. So what I tried to do here is to put in a small decision balance. Now, obviously, people on all sides of this, and I do respect people who are coming at this question from all different angles, and I don't envy your position to having to make decisions here, but we're all trying to get the same thing, which is a reduction in death and increased quality of life. But what I tried to do is look at a decision balance of providing safe supply, the pros and cons, or no safe supply, pros and cons. So with safe supply, the pros, there's many, but just in a nutshell, you may save some lives, particularly if it's used to engage patients onto proven treatment, especially in a contained environment like a supervised injection site where they can't take that medication home and divert it. The con is that it may cost lives in future. Diversion can increase street availability, the way it's rolled out right now, creating the next wave of opiate crisis, palliating a treatable disorder, and the legal risk of supplying unproven treatment. We all know the class action suits that are coming against organizations that promoted high-dose opiates for the pain crisis. So some of the pros of not having safe supply is resources can go to proven treatments and save lives, and do not add to the next wave of the opiate crisis. And there's many other things that I've already articulated in the talk. The cons are that some people who use drugs may decline or fail treatment, and they may die. Just like with cancer treatment, there's some people who can't access or who decline treatment. The legal risk of not providing safe supply when the federal government and BC is rolling out safe supply, you'll have to think of that on your decision tree. Next slide. So in summary, safe supply is an intervention that may reduce risk to some individuals, particularly when combined with opiate agonist therapies, but to others it may bring harm. Other evidence-based interventions exist, some of which I've talked about and some of the other speakers have talked about. Prevention, treatment, healthcare, housing, and jobs all reduce harm. Next slide. Here is the next two slides are some of my opiate-related research, including on pain. I did some of the first research with my residents around the link between seized drugs and the contaminated drug supply when comparing coroner data. Next slide. It's also part of the research. And next slide, I've listed some key naltrexone studies for you just because it's not a very well-known intervention. There's tons of evidence on buprenorphine and methadone, but I thought I would provide the naltrexone information because it's not well known here. Next slide. And I'm just recommending a book called Empire of Pain if you want to understand the origins of the opiate crisis and the role of the pharmaceutical agent industry. Thank you very much for your attention, and I'll take questions.
Thank you, Doctor. That was a lot of information. We're very appreciative for you taking the time to prepare that. So we're going to open up for Q&A, and we're going to start with MLA Milliken.
Perfect. Thank you, Chair. And I really do actually appreciate the fact that we offered the opportunity to go over those last few slides, because you actually answered one of my questions with this decision balance. One of the things, though, at the outset of your presentation, you had mentioned that you'd be listing potential. Oh, we're getting some feedback now. Listing potential pros and cons. And until that decision matrix that you put together, I was actually having trouble finding pros that you were listing. So with your comment then in summary where you say safe supply is an intervention that may reduce risk to some individuals, particularly when combined with OAT, but to others it may bring harm. That, of course, is opioid agonist therapy. My apologies on that one. Do you know of any studies or data-based backing to show that that is or is not the case?
What I presented was what is the hoped for outcomes. That's why some of the public health interventions have promoted trying safe supply, but there is no data, there is no published data that would support this intervention thus far. There's research being done now, but there's no supported data thus far. There's an anecdotal report that some individuals are saying they benefit.
And something else, follow up?
Yes, sir.
Something else that you had mentioned early on in your presentation, you had stated opioid-induced pain sensitivity, and then also pain in withdrawal. I was looking at, I could see a possibility where safe supply may be effective with regards to dealing with potential pain from withdrawal. However, I just wanted to see if you could expand on that, especially on the opioid-induced pain sensitivity.
Yeah, so ironically, first I'm getting some feedback, someone has their mic on, but ironically, opiates are very good to relieve pain in the acute setting, but very soon there are many changes within the nervous system that will make the person more pain sensitive. And then also once they're tolerant, when they have withdrawal, they can have generalized aches and pains, as well as pain return to old injury sites, even healed injury sites that were pain-free prior. So this tremendous pain that you can have can drive use. So it's one of the key risk factors with opiate use that's different than all other substance use is the tremendous pain people can have. Safe supply is certainly anything that can relieve withdrawal may have some benefit, but it's not a safe way to deliver that. Truly, to use evidence-based medicines, methadone, Suboxone has been shown to decrease pain by about 50% when people are converted over to it. And if you can detoxify someone and they can go on a non-opioid, this can also be an effective intervention if they don't have an underlying chronic pain disorder that needs an opiate for treatment.
Do you have a follow-up?
Thank you. And I will take the opportunity actually to shift us in a bit of a different direction. Just when the beeper went off, you had started what I thought was a potential part of a discussion with regards to, you'd mentioned Portugal. And Portugal has some notoriety with regards to decriminalization of drugs. It's also, it's my understanding that there may have been some successes with regards to bringing down overdose rates in that country.
Yes, very much so.
And if you could then potentially, because it's my understanding that they may have been able to and I'm not trying to answer the question for you or anything like that, but they may have been able to do it without using safe supply or supervised injection sites, is my understanding. But again, yeah.
Your understanding is correct. They took a treatment-focused lens, and how they decriminalized is not the way it's being proposed in Canada and elsewhere. How they actually decriminalized is if you were found with a substance, a small possession of small amounts, and they had it, they had documentation and agreed upon what level that would be, you would be brought in and interviewed by a social worker and sometimes others to determine if you have a substance use disorder. If so, you would be offered treatment paid for by the government up to a year, including residential treatment if needed, access to medical care, psychiatric care, all medications paid for that would treat your substance use disorder, and then vocational rehabilitation. Then they pay for the first 6 months to a year, they pay 50% of your salary to your employer wherever you can get integrated into the job force. So you go from being the least likely to be employed to the most likely to be employed. They offered housing, they offered all of this integrated care within the community, and it had extremely high quality of life improvement ratings from the people who participated. They dropped their overdose rates, their incarceration rates, their HIV rates, and they diverted some of that money to healthcare that had been to the criminal justice system. And then they used some of the money from the criminal justice system at a low level to help secure their borders from importation from that tainted supply. So they were able to, in this way, really help their society.
MLA Milliken?
Yeah, I would actually, you've essentially, it sounds like you've told us that it's actually quite a complicated, any potential solution is complicated and has many different factors. What
it is.
Yeah, and so taking from you on that, then what evidence-based medications and social interventions are we then lacking in our sort of armament to fight the opioid crisis?
Right. So some of the good things you guys have been doing in Alberta is you created a 24-hour, 7-day-a-week access so someone could get onto buprenorphine. So that's excellent. You're increasing both residential treatment and also second stage recovery, as well as sober living communities, because some people need years to fully stabilize given the years of use and damage to their brain and to their bodies and their emotions, etc. Other things we need are the evidence-based, both social interventions as well as evidence-based medications. And I had listed those during the talk. One medication that we don't have at all, like I mentioned, is naltrexone. I helped to spearhead a letter of 34 addiction doctors in 2018, and we helped Jane Philpott, then the Minister of Health, understand that naltrexone was an important thing in the armamentarium. And she got Health Canada to allow this medication to come in, but no health authority or province paid for it. And so on their formularies, and so people could not access this. So injectable forms of that and injectable forms of buprenorphine as well as all the other medications that I listed in my talk.
Did you have a follow-up to that, member?
I would have a question that would be unrelated, so if somebody else. And
Emily Yao, and then we'll come back to you.
Thank you very much, Chair. And Dr. Rieb, thank you so much for taking the time to speak with us. You have a very lengthy resume here. I'm just going to clue in on just one or 2 points of your resume, which is that you're a member of the Canadian Society of Addiction Medicine's Education Committee, as well as a key committee member with the College of Family Physicians of Canada's Competency Creation Working Group for the Certificate of Added Competence in Addiction Medicine. In your presentation, you mentioned that 75 to 80% of heroin users started out as prescription users, or they were given prescription opioids for their pain relief and whatnot. I think that's reflective of certainly our physicians contributing to this crisis. In your position, do you see more education, more competency being targeted at physicians to try to alleviate this issue, or? Yes.
Thank you very much for that question. Yes, so I've done addiction medicine for close to 30 years now and been working in pain medicine or pain rehabilitation as a family physician for about 18 years. And I have taught through the College of Physicians and Surgeons in British Columbia, through the College of Family Physicians. Also, I'm part of the Pain and Addiction Common Threads Committee in the United States for the American Society of Addiction Medicine. So I've taught nationally, internationally, and locally, and to med students and fellows, all trying to help with understanding rational prescribing. And I teach physicians on how to help bring down some of the outrageous opiate doses that we were doing. People are doing a much better job in the medical profession now with this. There are guidelines now. There used to be no guidelines on upper limits that you could go to. So I used to see patients come in very frequently on hundreds or thousands of milligram equivalent of morphine. And now that's very rare in the pain setting. In the addiction setting, it's still quite high. But we have done all this work to help mitigate over 2 decades. I've taught doctors on how to help mitigate and have more rational prescribing, and then to have it unleashed on the other end by saying you can just provide, safe supply. It's very confusing to doctors because all someone has to do is say that they have an addiction or take fentanyl once so it's in their urine drug screen, and then they have access to this very high potency opioids, whereas they've been curtailed on the chronic non-cancer pain side. So it's creating quite a bizarre environment right now.
Thank you. No follow-up.
Follow-up? Okay. Any further questions? I think... I could... Oh, MLA Milliken?
The question that I was going to ask was actually well done just previously. However, I do have another one that I could just, if you would allow, yeah. In your presentation, you mentioned that overdoses still occur with safe supply, and that most were due to the individual being alone. Given your experience, would a more effective prevention of overdoses be focusing on reducing the use of opioids by yourself versus toxicity of the drug being used?
Sorry, I don't think I mentioned anything about being alone, although that is a risk factor, using alone. And also,
it could have been another
just to clarify,
presenter.
Yeah, just to clarify, I don't think I said the first part of your question exactly either. But I'll address the issue of being alone. I didn't say that people overdose more with safe supply. We don't know the answer yet. That's being researched. The issue of using alone, obviously, that's one of the public health interventions, is trying to use with a buddy and trying not to use at the same time your buddy is using, to have naloxone present, to go to, if available, a supervised injection site, that kind of thing. That's kind of a base level of harm reduction.
Thank you. No, thank you.
Perfect. Emily Rosen.
Thank you. I just have one follow-up, actually, to my colleague MLA Yao's question. You raise an interesting point, I think, that the medical community and doctors undergo years of training and schooling to learn how to properly prescribe and diagnose medications. But in a safe supply model, individuals could just walk out and essentially get the drugs almost without a proper prescription or allowance. So would it be fair to say that the concept of safe supply almost undermines the medical community and undermines the work and the teachings that doctors do and go through?
On the one hand, I can say very much so. And at a bare minimum, it certainly confuses people a lot. There are certainly advocates in the medical community. There are a lot of public health doctors who think that this would be the way to go. But again, I liken it to when the palliative care doctors and the became involved in the treatment of chronic non-cancer pain, and anesthesiologists who'd only worked in the hospital, and they'd end up prescribing these high doses. They didn't see the impact. As an addiction medicine doc, I got the fallout from their prescribing practices. And so these public health interventions, though they look good on the surface that, oh, this is compassionate and may help, in the broad societal view, it may actually cause harm and also be very difficult for doctors to gauge how much to give. I may be proven wrong in the long run. That's the thing about evidence in medicine. So to keep an open mind and try not to demonize people who have alternate views. But I think trying to make the best evidence approach, there are other ways to tackle this problem.
Follow up? No?
Thank you. My question was a follow-up to somebody else's.
There we go. MLA Milliken.
Yeah.
Just a general question that I've put in some way, shape, and form to several of the presenters. This committee is tasked with examining several aspects of safe supply, including whether there is evidence that a proposed safe supply would have an impact on fatal or non-fatal overdose, drug diversion, or associated health and community impacts. With that in mind, is there any evidence that you know of that that access to a safe supply of opioids or other substances for people who are addicted to or dependent on these substances reduces their likelihood of suffering a fatal or non-fatal overdose?
We don't have any data on this yet. And in terms of, there's lots of anecdotal reports of drug diversion, however, right now.
Excellent.
But with any intervention, there will be individuals who benefit, just like when we prescribed very high doses of opiates for pain, there are some people who came forward who said, I can get back to work, I'm doing better. But there were other people who got addicted and harmed and their families were destroyed. So you have to look at the overall picture. And this is an intervention that has been rolled out in a population before we have the data for it. And also before we can look at all of the different harms that may be associated. Some of the data is kind of being targeted toward potential benefit, I feel.
MLA Milliken.
Thank you. And somewhat aside, on one of your slides, you had mentioned that palliating a treatable disorder is not good medicine. It's been discussed with a couple of the other presenters, but who would you say are the advocates then for safe supply?
I think it's a combination of a certain section of user groups that have been given voice and have their voice being heard now that may not have been heard. People who may not want treatment, but see it as it's more of a civil libertarian argument that they have the right to do anything, and they want to be able to use this like any other person uses any other substance. Personally, I don't even think the public can handle open access to antibiotics. I don't think open access to highly addictive substances is the way to go. The second are public health doctors who see the harm of people dying and wanting to make an intervention and seeing that this may be it. Also, the healthcare systems and all those social supports needed are not built in yet. They've been not funded by governments in the way that they needed to in order to avoid this crisis. So what do you do in the meantime? It's also, I think, there are advocates, parents and others who have lost people who have died to this, who have gotten on board to think this may be the solution. I personally don't think it is the solution, but because that's become, even government is funding some of those groups to be able to say, just like, you know, pharma did fund advocacy groups to say that they needed the opiates as well. So I think this is a bit of a tough topic and very emotional, but certainly I think people are going to die on either side of this issue. So it's difficult, but what you want to do is try to mitigate harm in the best way you can and bring forward the most evidence-based treatments possible and bring people into care as well as possible.
Thank you.
Thank you, Dr. Rieb. I believe that is it for questions on our side of things. So I just want to thank you very much for joining us, for your presentation, for your passion and the work that you do.